Good afternoon, everyone. My name is Dr. Roberta Laguerre-Frederique, and I'm the Director of Prevention and Outreach Services at the Dorothy Mann Center for Pediatric and Adolescent HIV at St. Christopher's Hospital for Children in Philadelphia, Pennsylvania. Our program provides a one-stop shopping model of care, providing, in addition to HIV care, primary care, family planning services, prevention services for all of our positive and negative patients, all under one roof. Our team includes 4 doctors, 2 nurses, 1 PA, 2 MAs, health educators, and many more. We've always had the benefit of having 3 to 4 full-time master's level social workers. The face of the HIV epidemic has changed a lot over the years, and our program has gone through many iterations, all in an effort to serve the families and especially young adults impacted by HIV infection. My early days at the DMC, I remember walking into an exam room and greeting the patient and the social worker, and after a couple of awkward minutes in my head thinking, why is the social worker still in here? And how does this work? And I don't know if I like this. What I quickly learned in those early days is that in this healthcare team that I had just joined, social workers played a pivotal role in direct patient care, and I must say that this style of care had a career-altering impact. One of our biggest challenges in HIV medicine has been to get more people engaged in HIV care, on ARV therapy, and obviously virologically suppressed. Our long-held approach to newly diagnosed patients was really one of a readiness model. And you see that depicted in this old narrative. And I remember learning this on my early months at the DMC, that I needed to assess the patient's readiness and work very closely with our social work staff to identify, remove, and mitigate barriers to adherence to ARV therapy. And once I did that, then, along with our team, then we initiate the patient on ARV therapy. We know that that process of readying the patient for many of our patients could take weeks or months, years for some of our patients. Over the years, we have found in our program that collapsing the time from diagnosis to viral suppression is most beneficial for our patients. We have also found that the negative psychosocial fallout that we all sort of intuitively feared for patients that would get started on therapy maybe too early was not only unfounded, but that early starts seem to have direct links to sustained self-care and success for our patients. In our experience, early engagement in HIV care works. Current ARV therapy, we have found, can really meet patients where they are. And it's not just that our ARVs are better. HIV research is overwhelmingly clear that people living with HIV at all CD4 counts are at risk for significant morbidity and mortality if they're not on ARV therapy, and specifically if they're not on therapy early. We know that early starts may not be right for everyone. We absolutely need to respect patients' autonomy and assess everyone's willingness to start therapy, but that our messaging should be very, very clear about the benefits and really the pitfalls and dangers of not starting on antiretroviral therapy. Adherence is still critical, and there's nothing about examining our approaches to starting patients on antiretroviral therapy or moving to earlier starts that means that we have to abandon our concerted efforts to help patients to be adherent, because we know that their long-term success is tied to adherence. We have come a long way from the dark early days of the HIV epidemic, and today we have patients who are living longer and healthier lives, as we all know with HIV infection. A 20-year-old who becomes infected with HIV may live into their early 70s, a life expectancy approaching that of the general population. But that this is most likely if patients are diagnosed early, immediately engage in care, and start and stay on antiretroviral therapy. For the first time since the start of the HIV epidemic, our collective advances in HIV testing, treatment, and prevention have put us within striking distance of an HIV-free generation. I believe that together we can reach it, we can touch it, but we have to be very together in our efforts to support routine HIV testing for all and back that up, most importantly, with early linkage and engagement in comprehensive HIV prevention services for our high-risk negative folks, as well as HIV treatment for our positives. If we are able to achieve these dual goals, we will together be able to see the end of the HIV epidemic, and to me that is really exciting. The CDC now recommends in all healthcare settings that screening for HIV should be performed routinely for all patients 13 to 64, regardless of risk. In our outpatient settings, every single young person 13 or older gets an HIV test as part of their routine screening. HIV testing that we have now is easier and provides faster results. We have an ability with fourth generation testing to test people and diagnose them as early as possible. And it's important for us to remember that every single time we test someone, we have this golden opportunity to engage someone who is HIV positive in early treatment and care and improve their outcome and decrease transmission. And we also have this great opportunity to link high-risk negative patients to comprehensive HIV prevention services. We have more retrovirals than for any other viral illness combined. But at that same time, we have lots of people living with HIV who are not benefiting from this great advancement. The old narrative was constructed to deal with intolerable drugs and understandably high rates of poor adherence. Right? It made absolute sense for us to try to get patients ready because it was so arduous to stay on the drugs of the past. Our current treatments, we have more options, we have better and safer options, we have clear mandates from the DHHS that we need to treat all patients and all CD4s as early as possible to prevent disease progression and to prevent HIV transmission. We have very compelling evidence to change our approach in many different forms. We know that near normal life expectancy can be achieved for patients with HIV if they're started with a CD4 count over 500. That's the optimal setting. Other factors such as smoking and, importantly, not achieving an undetectable viral load and a delay in starting antiretroviral therapy has significant impacts on life expectancy. Not achieving a viral load, 10 years of life loss it translates into. And delays in starting antiretroviral therapy, translation of 15 years of life lost, right? It really matters, the timing really matters. We now have an array of different prevention strategies for the truly diverse needs of both HIV positive and HIV negative individuals. Our prevention toolbox has a mixture of approaches, behavioral interventions that have always been part of our armamentarium and should always be, like reducing partners, condom use. These are our prevention strategies that we should never abandon. We have structural interventions like condom distribution programs, comprehensive sexual health services, education and screening for all routine HIV testing, needle exchange programs, and now we have an array of biomedical interventions, right? Taking antiretroviral therapy to help prevent transmission or acquisition of HIV infection. The HIV care continuum for us is a constant reminder of what we need to do and how we need to be better at engaging patients to take antiretroviral therapy. We see here that of all the people who have HIV infection in the United States, 87% of patients are diagnosed. Only 39% are receiving HIV care. Only 30% of those received a prescription for ARV therapy, and an abysmal 30% are virologically suppressed. Again, this really disconcerting mismatch. And San Francisco, we have always, at the DMC, been following their efforts because they've made great strides at each stage of the HIV care continuum. In 2014, San Francisco committed to being the first municipal jurisdiction in the United States to achieve the UNAIDS vision of getting to zero. Zero new HIV infections, zero HIV deaths, and zero HIV stigma. The key cornerstone of their plan focuses on easy access to antiretroviral therapy and same-day initiation of newly infected persons. So on the day that patients are given their diagnosis, starting antiretroviral therapy. They base this on evidence that the earliest possible treatment for HIV improves their folks' outcome and that the treatment can reduce HIV transmission. And it's just as simple as that for them. As they were looking at their approaches to starting patients on antiretroviral therapy, they really had to look at what they were starting with. And they were starting with a series of steps that many of us in this room are very familiar with. The person is diagnosed with HIV, they have an initial assessment and counseling session, and then they have a medical evaluation, and then after that, an ARV prescription, and then hopefully virologic suppression. What they sought to do in San Francisco, UCSF and San Francisco General Hospital teamed up to look at a new model called the RAPID model. And what they wanted to do was to collapse all of those initial appointments into one encounter. And what they did is they had patients receive healthcare and supportive services all in one session. So patients received social support, insurance access, HIV education, mental health counseling, transportation assistance, same-day appointments with an on-call healthcare provider, and samples were collected at that first encounter for lab tests. Patients were not required to receive substance abuse treatment or mental health care before starting ARV therapy. A 5-day starter pack of antiretrovirals was provided, and the first dose was given as directly observed therapy during the session. When they started to look at the data from this first project, they really wanted to map out clearly all the different approaches that they had gone through over the years. We all remember a CD4 guideline that a person with a certain CD4 count would get antiretroviral therapy. And then we moved to universal as we had more and more data that it was clear that everyone needed antiretroviral therapy. And then finally, this rapid model, right, where people get diagnosed and on the same day started antiretroviral therapy. The study patients were really not very different than most of the patients that we all see. Right? These were patients who had very high social needs, like so many of the folks for whom we would have historically delayed therapy. Here are the results. Take a look at those results, right? So at 3 months, 75% of the patients in the RAPID program had achieved a viral load to less than 200. At 6 months, 95%, both substantially more than in the non-RAPID group. RAPID patients were followed for 5 to 18 months, and 90% remained engaged in care, right? Adherence obviously was still critical, but remarkably achievable in this really complex set of patients. And so for us, this has been something that has really been eye-opening for us. I'd never assumed that every patient could start on the same day of diagnosis or have an early start. But the early data from this study and some other studies in the United States and abroad are really giving us food for thought that we need to start looking at this differently. Our own experiences at our clinic, we went to universal treatment when our guidelines changed, and over the years we've moved to sooner and sooner starts for our patients, and our experience really aligns with what these folks saw in the RAPID program. We have patients right now that I can tell you were started in the last several months on the first day of diagnosis who I could tell you for sure, if they came to see us 5 years ago, they would probably still not be on antiretroviral therapy as we were working on their problems. And they have been remarkably successful, and it has been pretty stunning for us, all of us, to see. The overwhelming evidence is that delays in linkage to care and ARV initiation hurts our patients, and it really presents us with a clear call to action. It's time for us to retire these long-held approaches. The 2020 National HIV and AIDS Strategy has as its goal 85% of people living with HIV linked to healthcare within 1 month of their HIV diagnosis, 90% of people living with HIV retained in HIV medical care, and 80% virologically suppressed. The model at our program at the DMC, though, is to get patients linked to care on the first day of diagnosis, right? That is the goal for us in every clinical situation, and if not on the first day, then very shortly thereafter. We, at our program, see every new positive as what we call a critical positive. A critical positive in medicine is a lab result that really has life and death implications. An immediate response is required by both the provider and the patient, and really the nature of the response really impacts the outcome. And really for us, there's nothing about a new diagnosis of HIV infection that doesn't meet that criteria. And really what we're trying to do with patients is to model urgency, right? We can't expect our patients to be urgent about taking care of their HIV if we don't model urgency in our approaches to getting them linked to care. When one of the medical providers from the RAPID program presented this data, this very compelling data about the success of the RAPID program at Croy, he was asked after the presentation on the podium by another doctor what he thought was the critical success factor for the RAPID program. He said the reason that the program was so successful is that they had comprehensive, excellent social work staff helping to prepare that patient to be successful. And I have to tell you, nothing about his response surprised me. So we know environment matters. And so what I've realized is that these very formidable challenges that we see our patients facing not only makes it hard for the patient to envision a good outcome oftentimes, it also makes it very difficult for particularly medical providers to see that that patient could be successful. We look at all of those challenges and think we have to delay, because how could they possibly be successful with all these things going on? And I have to tell you, it has been our social workers who have modeled for me and for our program the transformative impact of believing in every patient's ability to be successful despite their many struggles. I want to take this brief opportunity to talk to you about two kinds of patients that we have experiences with in our clinic. Two young men who have sex with men, both newly diagnosed with HIV, and really their stories are virtually identical, right? Long history of involvement in foster care, significant depression with heavy self-medication with marijuana, physical violence, homelessness, homophobia. But two very different outcomes. The first patient having the outcome that we all want for our patients, right? A really good positive outcome, virologically suppressed. And the second patient having a really negative outcome. The variable, though, that seemed to be the only real difference between these two patients is when we met them. The first patient we met on the day of diagnosis, in large part because at our program we started to do more HIV testing. So we started diagnosing more patients within our walls and weren't getting just referrals. So we had the ability to diagnose patients and talk with them right afterwards, right after they're given their positive test result. And we immediately started to pay attention to the fact that they immediately start, as we all know, constructing a narrative about what HIV infection is going to mean in their lives. And then we were able to seize on this golden opportunity to actually contribute to that narrative, right? Contribute to the construction of that narrative and hopefully get that patient to construct a narrative that was hopeful and positive for the future. And what we saw is that when we had that opportunity, patients were more likely to come back, more likely to be prepared to start on antiretroviral therapy earlier, start and stay on antiretroviral therapy. And when we had patients who were diagnosed, who were linked to care a little bit later, it just seemed to be a very different sort of encounter. We had patients who we now understood had constructed their narrative without us. We meet patients all the time, and I know all of you meet patients all of the time who have developed a very negative narrative about what HIV means in their lives. And I know that many of you have had great successes with helping patients to dismantle that narrative, to unwind it and replace it with something better. But I think probably most of us in this room would prefer to have the opportunity to help that patient to construct the first narrative, right? To help the patient with the initial narrative and help put them on a good footing to be successful, as opposed to having to unwind that negative narrative. In the last several months, we have fully embraced starting patients on ARV therapy on the day of diagnosis, when appropriate. Our virologic suppression rates hover between 75 and 83%, I am proud to say, compared with the national average of 30% overall, as I've mentioned, and an abysmal less than 6% for youth, right? And so it's a difficult population, and we're finding remarkable success in changing our approaches to when we start antiretroviral therapy. We have a clear call to action to test, link, engage, and treat everyone, early, everywhere. We want to meet patients where they're at, help them to see how HIV care, treatment, and prevention can fit into and enhance their lives, and help change the narrative with providers so that we can all help patients to engage and thrive. Thank you so much.